Good day, everyone. I am Christine, the moderator for this webinar. I welcome everyone to today's webinar, EMTALA 2025. I would like to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, PS, JD, RN, CPHRM, recently served as the Regional Director of Risk Management and Patient Safety for Kaiser Permanente, Colorado. I would now like to hand over the floor to the speaker. Over to you, Laura.
Thank you very much, Christine. Welcome, everyone. As Christine mentioned, our topic today happens to be EMTALA. And yes, there have been some changes, not very many. Really, the big changes are with the conditions of participation for hospitals. It relates to maternal care. I want to do just a brief history on EMTALA. It started way back in 1985. So in 1985, Congress decides they're going to go ahead and enact EMTALA. It went into effect about a year later in August of 86, and some changes over that time. And one of the first ones I just want to point out, it's called EMTALA. It references Emergency Medical Treatment and Labor Act. Initially, it had said active labor. That's no longer part of it. The female patient need not be in active labor in order for EMTALA to apply. COBRA, and now they changed it to EMTALA. Hospitals that participate in Medicare, they have certain requirements under EMTALA. 2019, there were changes. They actually updated the complaint manual, Appendix Q, to include EMTALA violations. Other changes, they're now going to look at 20 records in depth. If they come back, they're going to look at 10 more. They will add that surveyors are to look at the central log. We'll talk about that. They may provide, the surveyor may give you preliminary findings, but they won't tell you whether or not it's a violation. Well, in 2022, a memo came out, and that considered updating one of the injunctions from a case out of Texas called Texas v. Becerra. Moyle, this was the Idaho case, and so I mentioned at the beginning some of the maternal safety standards. This was a policy through the Biden administration where they're trying to reduce mortality and increase access to care for women who are having problems. It came out in November. So now we have a new rule. This is a rule in the manual. It's part of the Medicare Outpatient Prospective Payment Program. It addressed several key goals of the Biden administration in responding to maternal health crisis, talking about health disparities, and promoting safe care. It does not modify what we're talking about today. It doesn't change it any bit. Rather, it is new condition of participation where it's going to be addressed. First is an organization and staffing and delivery of service. And staff training is also in there. Organizations, it has to be well organized according to the standards of practice for OB patients. You have to have basic equipment. That means call-in system, monitor, fetal and Doppler monitor. You have to provide provisions and follow protocols according to national guidelines. We have to train our staff on what those policy and procedures are. Under quality assessment, this is for hospitals who do provide OB services. You analyze your data and quality indicators. You analyze and priority outcomes to develop and put together actions to improve these outcomes. Under emergency services, again, different tag number, you have to have adequate provisions and protocols following guidelines. Facilities, you have to set aside enough provisions for emergency. That's equipment, supplies, and medications. And then transfer protocols. Again, this is new. This is going to be, these are all new tag numbers that are coming out. You have to provide training annual on the policy and procedures, so they're all following it the same way. Phase 1, that's emergency service readiness and transfer. That's July 1. Phase in, this is for organizations, staffing. It's January of 26. OB staff training, QAPI program, that's January of 27. On EMTALA, there are several players involved. Now, the Office of Inspector General, they came up with some final rules regarding this issue, and it changed the civil monetary penalty or fine if we violate federal law. The penalty is for each and every violation. Physicians can be excluded from Medicare if they find out this happens. And then they look at aggravating circumstances. Okay, I'm going to talk now CMS and the EMTALA with the conditions of participation, just some examples of deficiencies. All right, the basic section, it's in section 2400, and it defines a hospital to include a critical access hospital. So pretty much all hospitals are governed by EMTALA. There is an EMTALA sign. This is one you have to post somewhere conspicuously in the ED. But overall, EMTALA applies to everyone who participates in Medicare. Includes anyone who comes into ED requesting care. What are the qualifications? What are the criteria that constitutes that? Some of our requirements, we can't delay. You can obtain basic information. This is what you cannot do regarding payment. You can't delay the screening exam or treatment. What you can do, again, there are two places in the EMTALA regs where they talk about whistleblower protection, two of them. If you have a patient who wants to leave, sign out AMA. Do the best you can to get that written informed refusal for care. Document the description of what risk you did tell them. On specialized capability, you are required to accept appropriate transfers of other patients if you have specialized capability. Capacity, that's the way you accommodate that person who needs examination or treatment. You do have to have policy and procedures, and there are multiple ones in this section. Penalties, non-compliant, they can be terminated from the program. They can exclude physicians from a federal program if it's gross and flagrant. So briefly on the sign, I said there had to be these posted. You must post them in ED, Section 2400. A copy is that required by the Secretary. Now, there are updated new ones here. Records keep them 5 years, and that's from the date of transfer. You have to keep a list of all of your physicians on your staff. For the community plan, clearly spell out which on-call services are going to be provided and when. Elective surgery, you decide if you want them to do that. And by the way, there's no exemptions, no requirement, by the way, that a physician's on staff take call. There's no requirement for that. You have to have a written policy for that on-call. On frequency, CMS does not specialize it. On consultation, you can consult with another physician. They do recognize some hospitals do use telemedicine for taking care of patients. This question came up now and then. Follow-up care. Include that the physician is responsible for when they're on call. Okay, I mentioned one of the deficiencies talked about a central log. Outpatient. And the screening exam, of course, that's either physical or mental. The screening exam is ongoing, and that includes providing ancillary services routinely available. They define labor in the conditions of participation. Now, briefly on Born Alive, this came up. CMS did add to the interpretive guidelines under 2406. So the complaint manual will tell the surveyor how to handle them. There is a Medicare Learning Network form on this. It established that degree of care has to be provided for those born alive or an attempted abortion. There is also a disability update. So a minor child can request examination or treatment from an emergency medical condition. So who's qualified to do this? Who's qualified to be a qualified medical provider? Because this person has to have access to all resources. EMTALA obligations end when they're admitted for inpatient blood alcohol tests. This always raises questions. Psychiatric, they considered stable when they're protected from hurting themselves or others. If you're the transferring hospital, send what information you can. And these are just my closing takeaways. Have resources for those behavioral health patients. Christine, that ends our presentation. Be ready for it when the patient does present. So thank you everyone for attending and listening. Christine, thank you for your assistance, and I'll turn it back to you to close us out.
Thank you, Laura. That concludes the session for today. Thank you everyone for participating. You may all disconnect now and have a great day ahead.